So welcome back to this PTAC public meeting. I'm excited to kick off our afternoon panel. At this time, I've asked our panelists to go ahead and turn on their video if they haven't already. They also know that they need to unmute themselves before they talk. And so to further inform us about the issues related to the social determinants of health and equity, we've invited a variety of esteemed experts from across the country. They represent several points of view, including providers, researchers, payers, and patient advocates. This morning, we learned about a handful of specific initiatives and some research findings. I think these panelists will offer some additional perspectives that will help us better understand the latest information emerging about social determinants of health and equity and alternative payment models. The full biographies of our panelists can be found on the ASPE PTAC website, along with other materials for today's meeting. So I'll briefly introduce our guests and their current organizations, and then I'll ask each panelist to please introduce themselves with their name and organization. Because this is virtual, I will prompt each of you alphabetically by last name. So first we have Dr. Marshall Chen, who is the Richard Parrillo Family Professor of Healthcare Ethics in the Department of Medicine at the University of Chicago. Next, we have Karen Dale. She's the Market President of AmeriHealth, Caritas District of Columbia, and the Chief Diversity, Equity, and Inclusion Officer of the AmeriHealth Caritas family of companies. Dr. Jane DeVoe is the John and Sherry Saltz Professor and Chair of the Department of Family Medicine at Oregon Health and Science University. She also co-directs the Bridge C2 Center. Next, we have Kathleen Noonan, CEO of the Camden Coalition of Healthcare Providers. Laquana Palmer joins us from the Foundation for Health Leadership and Innovation in North Carolina, where she is the Program Director of NC Care 360. And finally, we have Dr. Charlotte Yeh, who joins us from the AARP Services, Inc., where she is the Chief Medical Officer. So I am going to have folks introduce themselves, and why don't we try that? We have some, hopefully everybody is able to connect now. So maybe I'll start with Karen Dale first and then go down the list. Karen? Is she unmuted, team?
I think we might need to start with Dr. Chen. I think Karen is still having some technical difficulties that our team is helping her with.
We can handle that. Let's start with Dr. Marshall Chen.
Hi, I'm Marshall Chen. I'm a general internist and a health services researcher at the University of Chicago. I co-direct a Robert Wood Johnson Foundation program called Advancing Health Equity, Leading Care, Payment, and Systems Transformation. We work with 7 teams of state Medicaid agencies, Medicaid, managed care organization health plans, and frontline healthcare delivery organizations on payment reform to advance health equity.
Thank you. Dr. Jen DeVoe.
Hi, pleasure being here. Thanks for having me. Jen DeVoe, I'm a practicing family physician, been out here in Portland, Oregon for 20 years, serve as the chair of our Department of Family Medicine at Oregon Health and Science University, also working in implementation science and health services and health equity research here.
Great. Thanks, Jen. Kathleen Noonan.
Hi, thanks for having me. Kathleen Noonan. I'm the CEO of the Camden Coalition. We're based in Camden. We started doing care management for very, very complex individuals in Camden. We have, since starting doing that, we've done a lot of clinical redesign projects. We do advocacy, policy, and work all around the country. So I'll say we do that. Before coming to the Camden Coalition, I was at the Children's Hospital of Philadelphia for 10 years. I started a research center there and spent 2.5 years in the C-suite. So I have a good perspective on the hospital view of this and then the community-based organization. Thanks for having me.
Great. Thanks, Charlotte. I'm sorry, Kathleen. Next, we have LaQuana Palmer.
Hi, good afternoon. I'm LaQuana Palmer. I am currently the Program Director of NC Care 360, which is North Carolina's electronic platform that we use with linking health and human services together. It was the first one that came across our nation, and we were just great to be able to share with you all today. Prior to my role at the Foundation for Health Leadership and Innovation, I served as the Healthy Opportunities Program Manager in the Office of the Secretary, where they are currently working on the demonstration, which they received a 1115 waiver to demonstrate how we can use the Medicaid dollars to pay for those unmet social needs services. So excited to be able to share with you all today.
Great, LaQuana. And Dr. Charlotte Yeh.
Thank you. I'm delighted to be here. I'm Charlotte Yeh, the Chief Medical Officer for AARP Services, Inc. I work predominantly in how to bring the strength of the consumer voice, the consumer lens, to improvement of outcomes, affordability, and the experience of healthcare. I'm an emergency physician for 20, 30 some years. I was also a former regional administrator for CMS. So I like to say I bring the perspective of a provider, a payer, a bureaucrat, but most of all, the consumer.
Great, thank you. I'm just going to check and see if Karen's been able to get her computer issues solved. Is she on? And if she's not, I'll just ask. We'll have her introduce herself when she's able to get join the group. So thank you all for participating. Look forward to our discussion. First off, I have a series of questions that I will run through. Some will be directed to the entire panel. Others will be directed to select members, and I'll call on them as we go through. But also, panelists, if you're not called on a particular question and have a point of view, feel free to jump in. And we're going to go ahead and start with please tell us what you see as the role and the objectives of social determinants of health and equity in the context of value-based care. What specific activities related to addressing social determinants of health, health-related social needs, and equity are most important for improving quality and reducing cost in alternative payment models and physician-focused payment models? And we'll start with Dr. Chen.
Thank you for the great question. So I'm going to start with three simple principles for us all to keep in mind over the next hour. That the discussion is going to get very detailed, and I think it's easy to get lost in the weeds and to miss sight of the target goal of addressing social determinants of health and advanced health equity. So these are three principles that I think we'll come back to as a North Star throughout the hour. The first is to continually connect the dots. How does payment reform or a policy actually address social determinants of health and advanced health equity? I think overall in our field, we have too much magical thinking where someone will think about a policy intervention or payment reform, and it becomes almost a payment reform for payment reform's sake, as opposed to payment reform that supports and incentivizes care transformations that address a person's medical and social needs to advance health equity. So again, payment reform that supports and incentivizes care transformation that addresses a person's medical and social needs and advances health equity. The second general principle is that we truly need to keep the patient and community central. We talk about patient-centered care, we talk about patients and communities in our mission statements, but frankly, this is one of the first things to go when organizations operationalize efforts. So we tend to impose solutions on patients and communities as opposed to a true co-creation, co-implementation process. So one of the questions you asked, John, was, well, like adapting to different contexts. There needs to be flexibility to adapt to concepts to different contexts because patients and communities differ. And when you do talk with patients and communities, there are a couple common themes of what works. One is holistically addressing medical and social needs. So, which sounds a lot like geriatrics, which is probably the least subscribed specialty in medicine. And why? Because our system is not well set up to do that, to holistically address medical and social needs. Patients also talk about then addressing the structural factors. We'll talk more about that, things like housing, education, and all. And with the third principle, which is that we need to address both the structural and technical, as well as the personal and cultural. We tend to focus upon the structural and technical. That alone isn't enough. We also need to address culture for implementation, buy-in, and the mission.
Great. Thank you. Laquana Palmer, please.
Yes, I can definitely tie right into what Dr. Chen is saying. In North Carolina, we definitely were considering how do we connect those dots. And in many places we look at health and human services, and it's just very, very fragmented. So before we can even begin to even think about value-based care and alternative payment models, we had to back up a little bit. So it was like, wait a minute, hold on. Before we can move forward with this, how are we talking to one another? So in order to do that, we do have NC Care 360, again, is that electronic network that we're using with linking health and human services together. But it actually even goes beyond that. We are looking at the relationships that we have within, not only just at the community level, but also with our physicians and our providers as well. So with NC Care 360, we're not only just, again, looking on the community level as far as community-based organizations, we've actually backed up and looked at, hey, what about our providers? What about our payers? What about all these individuals who are talking to one another to ensure that they have a mechanism that they are able to do that? So in order to really look at value-based care and those payment models, we had to build an infrastructure in order for that to happen. So NC Care 360 is a part of that infrastructure that we are using specifically as we begin to, again, look at that demonstration that we have here in North Carolina. So I'll touch on that just a small bit on that. With that 1115 waiver that we received from CMS, and again, this was a brainchild that we had from Dr. Cohan at the secretary's level at the North Carolina Department of Human Services. This is a relationship that we have with FHLI and the department to ensure that NC Care 360 can keep going to do a lot of that work. But with the 1115 waiver, we have that demonstration that will allow us to be able to look at the work that we're doing in Medicaid, and again, pay for those unmet social needs that so many individuals are in need of. And later on in the discussion, hopefully on the panel, I can hopefully give some demonstrations as to how we were able to look at that even right now during COVID, and looking at support services and linking them to a number of our COVID-related healthcare facilities that were able to provide services as well. So again, when you're looking at that payment model, you have to look at connecting those dots and building an infrastructure for those things to actually happen.
Great, thank you. Dr. Jenn DeVoe?
Great, thanks. I would absolutely echo what's been said already about connecting the dots and keeping our patients and communities central. One of the areas that I've had the pleasure to work on this year with the National Academies is primary care, the foundation of our healthcare system. There's a lot of great updates on the evidence on how to implement high quality primary care in our country, rebuilding the foundation of healthcare, ensuring that we have strong primary care, and ensuring that it's not only the primary care teams that are addressing the social needs of our patients and identifying the social risk of their communities, but the entire healthcare system. When we first started talking about this several decades ago, I was concerned about, when we look at the pie, about 5% of our resources right now from healthcare go to primary care. The other 95% don't, yet everyone in our population needs primary care. I was concerned that much of the conversation was about, let's take out of that sliver everything that we need to connect our systems with social service organizations to address social needs, to identify social risks. So it's I guess I'm optimistic that we're beginning to look at the rest of the pie. Some of the ways that I think we really want to hold our large healthcare systems accountable, and many of the places where those other 95% of dollars go downstream. And this is something I think CMS can do, other payers can do as well. Not so much saying, if you have a readmission, we're going to penalize your system, but let's think about ways to incentivize your system to connect to the NC 360, to have a chief community officer that knows your community, that's connected to your community. That person should also be working in your community. Maybe it's someone at the food bank or a housing resource. A chief primary care medical officer knows every single primary care resource in your community, supports those resources, connects patients back to those resources when they do get discharged from the hospital, supports the comprehensive care by the team, continues to push the workforce training out into that community so that we can have a more robust workforce in our community. All of these things, in addition to focusing on the individual patient, as best as possible addressing their social needs while they're in the healthcare system, most of our work needs to be investing in our communities, connecting those dots and building that infrastructure. So tangible ways to do that, I think, are not only looking at how are the patients treated within the system. Hopefully they spend very little time in the hospital or in the primary care setting. Most of their lives are spent out in the community. What are we doing to improve our community? What types of dashboards do we have in the healthcare setting to follow? Is the third grade reading level of that community improving? Is the housing improving? Is the food insecurity eliminated? Do we have no further patients that are living in food deserts, et cetera? So very uncomfortable for traditional C-suite leaders to think about those types of dashboards, but that's really where we need to move the needle. Thanks.
Thank you. Kathleen Noonan.
Right. Well, I'll just add something to the conversation that we haven't talked about yet, and it's about flexibility of dollars. Here's a story. We recently at the Camden Coalition put out an RFP for our health systems and FQHCs, and we now work broader than Camden. We're really in South Jersey to do a pilot with us where we would be redesigning standard of care and protocols in the emergency room because of so many pregnant women who are coming into the emergency room. And as you probably all know, it's not standard of care that when that woman leaves the emergency room, anyone is checked to make sure she's connected to prenatal care and makes that appointment. And so we are working with health systems in South Jersey to do that. And we only had $10,000 to offer them in flexible dollars. And every large health system applied to be part of our RFP, as did all the FQHCs, so much so that we had to go to a funder to get more $10,000 pots. And it just showed us, again, how not only are our clients in very inflexible positions, but our providers are. And the idea that they could have $500 to work with a client to be able to help them that day was so important to them and so valuable. And so I just want to say that whatever we think about, we have to have flex dollars. We have one hospital in our area that every year gives us $25,000, one of their main primary care practices, so that we can then flex fund for them whatever a patient might need, because they're not really allowed to do that, but they can do it through money to us. So I think this is a really important thing to think about when we're thinking about social needs. And I'll leave it there.
Great, thank you. Next, we have Karen Dale, and I'd like Karen to introduce herself because she wasn't able to earlier, and then provide her point of view. Thank you. Is Karen still having technical challenges? She might be. Let's go to Dr. Charlotte Yeh.
Thank you. So ditto for all the comments of the other panelists before. And Dr. Chin, I really appreciate your talk about making sure we stay consumer and person-centered. So building on the comments earlier by Dr. Joshua Lau, that we have been underutilizing, undertapping the consumer engagement arm. So I'd like to say that when we talk about SDOH and other factors, there are missing opportunity levers just by engaging the patient and the family. And I'll give you 3 key examples. So number one, we seem to think that only managed care or Medicare Advantage is the only route for creating value-based care. I'd like to say, what happened to fee-for-service? So I operate very much, and we do a lot of our testing is in the Medigap plan, which is the most perfect example of consumer engagement because there's no provider network. Your only touch point is through the consumer. We did care coordination programs that included SDOH, like referring people to transportation, helping them with their financial payment for drugs, helping them with personal family issues. And we were able to demonstrate, talking only to the consumer, a reduction in hospitalization, ED visits, a reduction in falls, and my favorite, 44% less likely to move into a long-term care facility and be able to stay at home. And best of all, this was a boon to the physicians because they weren't having to track and capture all of this data and do all of this work themselves or through their teams. We were doing this through the multidisciplinary teams through a Medigap plan. So to me, we have an untapped opportunity in fee-for-service. The second example I would give is even if we solve for all the structural and technical services that Dr. Chin mentioned, we have forgotten the person in the middle of this. You and I all know two 80-year-olds, and I'm an emergency doc, come into the emergency department. They can look identical on paper, but we know one's going to walk out of the hospital and the other is at the end of the road. Why? Because we have failed to take into account personal skill sets, characteristics that I now call the personal determinants of health, and we should call those out. It's under this rubric of resiliency, the ability to adapt and cope. We found in our population that those who were low in resilience cost 24% more PMPM. If you are low in purpose, you have no reason for living, you have 12% lower PMPM. If you are severely lonely, you cost 20% more PMPM. In fact, we looked at 5 protective factors from resilience, purpose, locus of control, optimism, and social connections. And we found for every one of these positive protective strength building skills that you had lower depression, lower reported anxiety, lower fair and poor reported health, and more functionality. And in fact, for every one of those personal factors that we help build, the secret sauce in helping you live well, we dropped $1,356 per person. And number 3, when we talk about equity, I would ask that you include, in addition to the really, really important race, ethnicity, sexual orientation, that you add to your discussion of equity ageism. I just read on a study that came out of the UK that clinicians are less likely, they only prescribe digital health tools to people over 65, 4%, much less than they do for the 18 to 45-year-olds. Because there is this inherent bias that the older adults know how to use technology. Yet we have ARP survey data that last year, 72% of people 50 and older actually bought new technology in the midst of the COVID pandemic. 77% of 70-year-olds actually have a smartphone that they use on a daily basis. So it is time for us to think about the change. Only 5% of marketing images actually show an older person using technology. So if you have no vision or hope that you are capable and you have no sense of purpose in your community, why would you change your behavior? So I would like to have us think about ageism as kind of that my third recommendation for adding to equity.
Great, thank you. And thank you. One more time with feeling, we're going to try and reach out to Karen Dale. Karen, are you with us? All right. Well, I'm hoping, fingers crossed, that she will get her computer issues solved here quickly and can join the panel.
I think, am I now? Can you hear me?
I can hear you now.
Oh my goodness. We've been working on getting me connected since 1:20. It's just
well, Karen, that in of itself is a major feat. So you have the floor, please. We're anxious to hear about you and what you have to say for the first question. Thank you.
Sure. Karen Dale, I'm the market president and CEO for AmeriHealth Caritas District of Columbia. And I am also the Chief Diversity, Equity, and Inclusion Officer for the AmeriHealth Caritas family of companies. So I thought, wow, let's see, the first question is about which activities are useful across diverse populations?
Yes.
Okay, I'll be brief. A couple of thoughts. The highest on my list is member engagement. We often are working hard to design something for someone with whom we rarely have enough of a direct conversation about what we're planning to build for them. So much more inclusion, which is an important part of equity, is having those direct conversations and respecting, honoring, and celebrating their voices. If they disagree with us, right? That's awesome. If they have thoughts of their own about something as personal as their healthcare and the delivery system, which provides them with services. We should focus more as well on health literacy, just because it's what we do every day. Sometimes some of what doesn't happen is based on not knowing. And it's not knowing because they're not smart and capable people. It is not knowing because we've designed such a complicated system. And so ensuring that we work to provide information in simple, clear terms that you don't have to be an insider to understand is useful as well. The other piece is around really leaning in when we have conversations to understand barriers. I often, when I speak with our members, I start with a question. I say, what is it that we could have done differently, right? That would have helped you to utilize the full variety of all the services we have available to you. In the district, we have the richest benefits. We have the most people covered. So to me, I look in the mirror first and I say, what else could we have done? And that very open-ended question has given us so much rich information to better understand where we can improve, though we're very well intentioned.
Thank you, Karen. It's great to have you with us today. I'm glad we got you sorted out.
It's been a journey.
Yeah. And for those of you who are looking at Karen's photograph, her last name is Dale. I think the K got flipped in there accidentally, so I'm not sure that can get corrected, but just want to make everyone aware. On the next question, COVID-19, public health emergency, it's elevated the importance and urgency of addressing social determinants of health, health-related social needs and equity within the healthcare system. And so I'm asking, can you speak to the lessons learned related to COVID-19 that have informed or extended your ideas on how initiatives for addressing social determinants of health can be incorporated into alternative payment models and physician-focused payment models? And the second part of that question is, are there any specific lessons connected to addressing equity? We'll start with Kathleen, then go to Laquana and Charlotte. Kathleen?
Great, thank you for this. When COVID-19 first hit in Camden, Camden City developed a mega site like everyone was doing. And our Community Advisory Committee, which is a committee of our board, so two of my trustees are people who live in Camden, told us quite loudly that it was a terrible site for the mega site in Camden. It was a site where the prison used to be. There was no public transportation. And I told all of my partners, and we have a coalition, so I meet with them, that, we thought, my community advisory committee did not think it was a good site. And the horse was out of the barn, and the site went forward, and we did a lot of shots for people from the suburbs, a lot. And so because we are a coalition and we come together, I was able to tell my community advisory committee that we were patient and that, we were not going to burn effigies. We were going to sort of have a conversation about what went right and what didn't. And we did in the summer, about 3 months after the site went up. And we decided that the next time we were going to do COVID sites, because that one came down, we were going to do community embedded COVID sites in places where there was high walking traffic and public transportation and all of that. So whoever said on the panel, and I know a couple of you did, that you have to engage with community members is absolutely right. But then you have to have a forum for that, right? So it can't just be one-off. It's got to be some ongoing, regular forum. And we were lucky enough in New Jersey, right February 2020, that the governor passed something called Regional Health Hub legislation, and the Camden Coalition is one of those. And we receive Medicaid 50-50 match dollars to be a convener of multi-sector partners. So as this mega site was going up and then coming down, we were actually sort of getting our sea legs on being a regional health hub. And now through the state and the county and the hospitals, we're really convening much more regularly than we used to about how to do this work. And that includes our community members. So I can't underscore how important that is. And I was at a health system for 10 years, and I can say that that was really not a regular part of our practice. It was very much a one-off kind of thing.
Thank you. Laquana?
So for our COVID work, we had a number of different things that just really happened to work in our favor as we were preparing for response. And I'll share with you all that prior to moving over to the secretary's office, where I was sitting when, COVID first, began to come across a lot of our screens, I just transferred from the Division of Public Health Preparedness and Response branch. So I was very, 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 very familiar with how response work and just really looking at interoperability and ensuring that we're able to reach our communities that have access and functional needs. So you have that one element. You have the next element of having NC Care 360. When we looked at COVID, we were building the plane and flying it at the same time. That just means that we were in the process of actually rolling out NC Care 360 as an electronic platform statewide. So instead of rolling that out at the end of December, we actually rolled out NC Care 360 at the end of June. So we were able to expedite using NC Care 360 across the state to use that as our leverage for interoperability to link up to those community-based organizations, our healthcare systems, and then also our other folks in public health as well, and DSS. So you add that element. We were also building a workforce of community health workers as well. So when you take building a workforce of community health workers, you then develop a COVID support program that is then onboarded onto NC Care 360. And you use those two things together where you have your community health workers on the ground who are using NC Care 360 along with those COVID support program that has things such as income support, has a number of supplies that individuals may need. And these are things that individuals needed while they were living in isolation and quarantine. So if you put all of those things together, we had a great program where we were able to use this just throughout COVID to help with linking individuals to those support services. And at the time, we were not under managed care yet. So we were using a fee-for-service model. So using that, we were able to help with paying for a number of those different services, using our CARES dollars to ensure that those that were living in isolation quarantine were connected to the resources that they needed as they were being tested for COVID and also looking for vaccine sites as well. And using that NC Care 360, not only just the platform, but the whole network as a whole, whether we're sending messages through our website, using our listservs to get additional messages. We just used all of our different networks of NC Care 360 to ensure that each individual was connecting to one another. And that just has really helped us with even growing a number of different programs across the state.
Great, thank you. Charlotte? You're on mute, Charlotte.
Is that working now?
Yep.
Great, okay. Thank you. So I'd like to highlight some of the ahas that came out of the COVID experience. We all know about the vulnerabilities of older adults, marginalized communities that were all highlighted by COVID. But here's one I don't know if you've been thinking about, is the impact of hearing loss. So about 2/3 of people 70 and older have hearing loss that is clinically significant, about 40% of 60 and older. It turns out, and I learned this through my dad, who was 92, with severe hearing loss, that as we shifted to technology and telehealth, et cetera, that you can't communicate if you can't hear. So think about something as simple as mask wearing, and I'll just show an example here. How many of the masks actually cover your mouth and you cannot read lips and you cannot communicate, you cannot see emotion? On top of that, how many of you who are switched to telehealth during COVID actually made sure that you had captioning capability? It turns out there's free captioning services through the FCC that you can get on your telephone, that you can get on your computer, but it doesn't necessarily apply to telehealth. So we literally had to adapt and put a tablet next to my dad's computer so that he could actually have free captioning off of the tablet through apps so he could follow the conversation. And out of that, we learned that if he took his tablet or phone to the physician's office when you could go to the physician and use captioning, he could actually communicate and understand. Why is this important? There's a recent study out of Johns Hopkins that showed that people with a lot of trouble hearing are 46% less likely to have a usual source of care. Think of what that means to getting a primary care physician. That you are 85% less likely to have a usual source of care, 60% even with a little trouble hearing, and it impacts your ability to fill prescriptions and communicate. Simply helping and testing for hearing and thinking about how you communicate for the older Medicare beneficiary is hugely impactful. The second is ageism. I'm going to go back to that. As I mentioned earlier, 40% of our Medicare supplemental population have a negative perception of aging, costs them 33% more PMPM. This is hugely impactful. There's one study that says it costs us $63 billion. And you have a 55% higher rate of hospitalization, just simply by your view of aging. And yet, did you notice during the COVID pandemic, everybody's mental stress and mental health burden went up? Absolutely across the board. But if you look at it by age bands, it's highest among the young, lowest among the old. Why are we not tapping into the assets, and how have older adults learned to cope with stress and anxiety, and can we teach that across the population? And then finally, I don't need to speak about loneliness and social connection, but we identified that early on. We found loneliness was the single biggest predictor of dissatisfaction in healthcare among our older adults, and yet we never talked about it. And now with COVID, we've highlighted the criticality of social connection, being in your community, staying connected, and not just staying in home.
Great, thank you. Are there any other panelists that wanted to add a point of view on this particular question?
Marshall here. I'll add 2 points. One is that COVID demonstrated that the public cares about equity, that for some of the public, this was a greater awakening of the realities and existence of inequities. And in some ways, the public is ahead of policymaking. So there's a hunger for action on equity. The second is that the COVID pandemic led to disruptive innovation within healthcare that work around things like reimbursement of telehealth or expansion of scope of practice basically broke years of political and organizational roadblocks. So let's show that transformational change can occur. It sounds ridiculous, but the idea that having a healthcare system and payment system that enables providers to address medical and social needs is revolutionary. Well, that's what it requires, and COVID demonstrates that we can do disruptive change.
Thank you. I wanted to take a minute and ask for my PTAC colleagues if they had any questions about this particular section before we move on to the next question. Any of the PTAC members have a question? Just raise your hand, jump in. All right. So we're going to move on to the next question, which is to get the panelists' thoughts on opportunities and gaps related to the collection and use of social determinants of health and equity-related data. Within the context of optimizing value-based care in APMs and PFPMs, what would it take to ensure that health-related social needs and social risks are universally screened by all healthcare providers and in a standard way? In your experience, what are the best or most promising approaches for facilitating this type of data collection and sharing? And again, we'll start with Laquana, move to Charlotte, and then Karen. Laquana?
I'll say that one of the greatest things that we've seen here in North Carolina is the actual use of screening questions within the healthcare settings. In North Carolina, we do have SDOH screening questions that we have shared throughout the state, and we actually took those screening questions and embedded them in NC Care 360 as well. So in order to have those screening questions, And we're talking about what are some of the barriers or gaps that we see with collecting those screening questions. It is down to the patient level. So if you're sitting with a patient and you have a provider, and in North Carolina, with those screening questions, we're using them in a variety of different settings, not just our healthcare settings, whether you're a community-based organization. We're using an approach where we're going through any door to be able to ask these questions. So you have these questions that are available, and when you begin to ask them, sometimes there are barriers with that provider that is asking the question. So we have to start there with building a workforce that getting more comfortable with asking these types of questions. Whereas in the past, we have maybe been very focused on the medical needs. And now that we are addressing those non-medical unmet social needs, that is something that has to be done concurrently. And we're seeing an issue and a gap with having a workforce that is either has the time, because sometimes we're seeing time is an issue to be able to implement those questions, or even having the staff that is just capable of asking those questions. So it's the number of different things that have to be addressed before you even get to the point where you are taking the data from something like NC Care 360. And yes, in NC Care 360, we're able to track outcomes. So if a question is asked, if a need is identified, if these assessments are happening, these things are in place, we can't get that information unless a person is very comfortable or gets more comfortable with asking for a person's race and ethnicity, gets comfortable with asking questions about age, gets comfortable with asking questions about interpersonal safety, and a number of other different determinants that we have, that serve as indicators. So before we can even get to that point where we can even track and look at what those outcomes and those trends look like, we've got to go back to, again, that what I say, patient and care level, to ask those questions of those medical homes first.
Thank you. Charlotte?
Thank you. Just building on Dr. Palmer's comments, totally agree that starting simple with the screening questions before you dive in to get the really deep questions when the screenings turn positive, we found that we can then go back to our members or patients to get a little deeper dive. But what's important is not just the comfort of the person asking the questions, but we found and we learned in surveying on these very sensitive topics, nobody's going to raise their hand to say I'm lonely or I'm in financial distress or I'm depressed. People, there's a huge stigma associated with it. We found using more technology approaches were more effective because they were non-judgmental. That is hugely important. We found use of IVRs, use of technology-enabled screening questions, survey tools, as opposed to using a live person, was far more effective, and people would answer because it was non-judgmental. So I'd like to, as you do the data collection, is to really keep that in mind. And the second thing I wanted to add is also what's missing that I think is critically important going forward. It has to do with caregiving. So right now there's some 53 million adults who are caregiving for everything from children to adults. 42 million of them are for the 65 and older, the Medicare beneficiary. I don't know how many of you know that 7% of caregivers are 75 and older, and 3/4 of them are caring for people that are 75 and older. We know that there's huge stress on the caregiver. They are spending anywhere from over $7,000 per person in out-of-pocket expenditures that we don't capture. The average caregiver spends 24 hours per week caring for a loved one. That 24 hours, over half of it is involved in advocating in front of government agencies, community organizations, and provider health systems for the care that they need. 6 in 10 of those are actually medical services that they are providing, catheter care, the IV hydrations, injections, et cetera. And nowhere in any of the metrics that I've seen have we captured the intensity of the caregiver burden. How much time are you spending? How much finances are you spending out of pocket? 51% of that actually is for housing costs, believe it or not. So imagine the importance of housing and SDOH. And then thirdly, about the stress on the caregiver themselves of being able to care for themselves. Nowhere do I see us measuring that. And if you want to demonstrate effectiveness in SDOH, if you want to demonstrate effectiveness in the shift to home care, if you want to demonstrate effectiveness in where you're spending their money, we should also be measuring that reduction on intensity and stress on the caregiver. So,
thank you.
my 2 cents.
Thank you. And I think that's more than a couple cents worth. I wondered if there were any panelists, other panelists that wanted to provide a point of view here.
We run an Accountable Health Communities grant, a large grant where we're social screening in so many sites in South Jersey. And I would say that the number one thing that we see as a problem is that the whole care team doesn't really see the resources connected to the screens. And so if there isn't really a very, like visible connection between the screen and the resources that are available, people from the receptionist, right, to the med tech, to the nurse, have some ethical problems with the screens. And so I think we just need to do a better job of showing people that there are resources connected with the screens.
Great, thanks, Kathleen. Jen?
Yeah, I agree. I think screening is all well and good. I think it's important to identify medical needs as well as social needs, but I think we need to get moving in our country on looking at the social deprivation of the community. Kathleen, you mentioned that your advisory committee knew the communities that needed the COVID vaccination sites, the testing sites, the resources, and yet we continue to focus on where it's easiest, where we can get the biggest quantity of people through the door. Quantity does not equal equity. We saw that time and time again with COVID and the services we put out into communities in exactly the wrong places. We have sophisticated geographic information systems. We have sophisticated data. We know from other countries like New Zealand and the United Kingdom and from the work in Massachusetts and other areas within our own country that you can identify a community and a place where a patient or a consumer lives. You can understand the social deprivation in that community. It might not be that that individual has every single risk factor that people in their community does, but it's pretty likely that the situation in which they live is impacting their health. So there's so much that we can be doing in a very simple way. I say simple, it seems like it's taken us a really long time to identify service providers, whether they're healthcare service providers or housing providers, education providers, and say, you are located in an incredibly deprived area. You deserve additional resources. Yes, we're going to hold you accountable for spending those resources, but we're going to be incredibly flexible in having you listen to your community and what they need and measuring your outcomes in very creative and sustainable ways. Otherwise, we are going to continue to have misaligned incentives where healthcare providers and all the other providers are going to go to places where it's easy to keep people healthy because those people have money and have resources. And if we don't begin to really understand what it takes to improve the health of all communities, we are not going to make it very far with screening every individual patient at every visit. Oh, and by the way, the people that have the most social needs don't often walk into healthcare settings, so our screenings are missing them.
Thank you.
But if I could just add on to that a little bit more as well, I totally agree with you in saying that, just identifying, what the needs are is not enough. But something I'll tie on to that as well is when we're looking at our community-based organizations who are leaning on to provide a number of these services and resources, we're finding that a number of these what I call grassroots, homegrown, those individuals that will crawl under the bridge for you to pull those individuals out to find out exactly what is going on. Those are the organizations who lack sometimes the infrastructure. They don't have the big boards that are available to help them with pulling in the number of dollars and things. So we're finding here in North Carolina where we are using capacity building dollars to help with those organizations who are doing more of this grassroots work, to help them build up to the point where if we have a community health worker who is able to help them identify what the needs is, we have those other grassroots organizations that are then able to work with those community health workers to ensure that we're linking to those individuals. So I think it's important that as we are looking at value-based care, as we're looking at all these different models, and you're building those resources for those individuals who are going to want to tap into those organizations, we're going to have those community investments into those smaller organizations to be able to help with doing this work. Because again, I totally agree. Those individuals who have the greatest need, who have those access and functional needs, there are those individuals who typically, like you said, are not going to walk into this building. I come from a background where I would wear my jeans, my sneakers, and my t-shirt, and I would go out there and I would be the streetwalker looking for folks for those needs. And now using this as our opportunity to help go back and make sure a lot of those organizations have the resources that they need to make sure that they're linking those folks in. So I totally agree with you.
Great. Thank you.
I'd like to add just really briefly just how much technology is an enabler to everything that we've been discussing. You know, to reduce the stigma was already mentioned, make it self-service. Also leverage things like an HIE that can house information for all the points of care. And you can also build in many mechanisms to close the loop so that those smaller community-based organizations just have to get the information in, right? And that's a huge role that the managed care organizations can play as well as aggregators and democratizers of data.
Thank you. All right, we have a couple questions to get to before the last concluding question, so I'm going to motor on here. The next question is ways to properly account for all aspects of patient-centered care, ensuring health equity is a priority. In your experience, what types of care delivery innovations or practice transformations and alternative payment models, or PFPMs, would have a direct impact on improving health equity? We touched on some of these, but also what types of data have the most potential for measuring the equity-related impacts of these types of innovations? I'm going to ask Jen to start, then Kathleen, and then Marshall. Go ahead, Jen.
Yeah, I know there's several organizations based in communities doing incredible work with accountable care organizations. I do want to lift up one example from Hennepin Health Center in Minnesota, and the work that they're doing in, going beyond using their hospital records, but also bringing in Department of Corrections data from housing agencies, foster care, and identifying a very vulnerable population of patients that they're then able to address social needs as well as medical needs, dental needs, mental health care needs. And this has, again, linking back to some of the points that have been made, flexible money to go to the community, identifying the community, linking them up with primary care, mental health care in very intensive ways, and then connecting all of the social services communities, organizations at the local level. So I think that's one example of innovation. I know there's many others. You all represent some of them, but was just really impressed. And then beginning to look at metrics. I know it's certainly not all about saving money. It's about improving health, but very impressive that they have reduced medical expenditures by 11% annually for this population, acute care use and emergency department use decreasing by almost 10%, and then utilization of the outpatient care and primary care mental health care services has increased, continuing to look at overall metrics of population health care quality improvement and equitable quality and improvement in health there as well. So one example where if you give an organization that's connecting communities together some dollars, hold them accountable, be flexible and comprehensive in the way that it gets spent across the different organizations, I think we're going to see some really great improvements if we continue to expand on those types of demonstration projects. So kudos to Hennepin, and really impressed with what they're doing and what many of you are doing.
Thanks, Jen. Kathleen.
Sure. The Camden Coalition has been running a regional health information exchange since 2010. And we, I think maybe the new parlance is community information exchange, and that's probably what ours is. We have, it's not focused just on the health systems. We also have shelter and food and other social services in that exchange. We've also been running an Aunt Bertha referral platform for about 7 years. So we have we have years of experience in these things. And they are really important. They are like the foundation, right? You need those things in order to even create equilibrium between the health systems and everybody else, and to be able to see patterns. But Also important on the practice level, you asked about data and what data you needed to collect around equity. You have to ask in your practice, why are there no-show rates? Why are people not showing up? To better understand your problems. You have to accept walk-ins. I mean, these are just after years of doing this work, these should not be think about. These are have to do's. Child and parent visits at the same time, parent and elder visits at the same time, caretaker and elder visits at the same time. I take care of this person. They also treat them at the same time. Visits to the community. These are things that have to be part of the standard of care and data points that we collect. So that's sort of you need a regional data platform that connects to a statewide platform, but then you also need to really, really get at some practice changes and some qualitative data issues that are really important.
Thank you. Marshall?
So when you look at what works for improving care and addressing social terms of health and advancing health equity, it's not rocket science. It's basically interventions that enable close relationships with patients, interventions and systems that holistically address that person's medical and social needs, and systems that allow close follow-up and monitoring of patients. It's what many people have been talking about the past hour, is basically being able to spend time with the patient to understand them and then address their medical and social needs. So it means team-based care, care coordination systems, seamless systems of care that integrate clinic setting, home setting, virtual care, inpatient care. It's care across the continuum. So Jennifer has eloquently a couple of times talked about the partnership of healthcare system and the social service sector in addressing geographic-based the social deprivation factors and all critical. Is primary care with access to specialty care. Jennifer mentioned one of the two important NAM reports that came up this year that are remarkably similar. There's a report on high quality primary care and one on the future of nursing. Both have a very heavy social terms of health equity emphasis, talking about the types of systems, reforms, payment changes that need to occur to support these efforts. So I'd recommend that the panel looks at those particular recommendations. It means supporting community health workers, peer navigators. Regarding data, the data are critical for both identifying a problem, designing interventions, and then eventually linking them to reimbursement and payment to support and incentivize these efforts. So it means doing things like stratifying clinical performance measures by social risk factors such as race, ethnicity, socioeconomic status. It means that looking at over time, is there improvement in performance? Is there attainment of appropriate levels of absolute performance? How do people do against their peers, comparing apples to apples, for example? Then I think it was either Kathleen or Jennifer also mentioned the importance of measures which may be new to healthcare, but absolutely critical for population health. So metrics like high school graduation rates, housing rates, employment rates, measures of community social cohesion, all critical, we know, for then improving community health outcomes. Payment, I'll talk about. I think we have a question coming up specifically about payment. I'll save my answers for that later.
Yeah, thank you. Let's go ahead and move on to our next question. And this is, what are the most effective methods for collecting demographic data for equity? Again, Marshall just talked about many variables that could help assess equity, from race and ethnicity, disability, primary language, sexual orientation, and gender identity. So the question here is, who would be the best entity to collect this data and how? And we'll start with Kathleen, then move to Karen and Laquana. Kathleen?
Yeah, I don't think there's one best entity, just as my answer. I think that we should all start collecting this data and then have a sort of embarrassment of riches with data, and then figure out sort of how to make it as, as clean and as we can make it. But I don't think there's one particular entity. I do know that at the Camden Coalition, we try very hard. I know that community health workers are sort of the thing that we're all talking about, but the truth is that the med techs and the receptionists, they're all part of the care team. And so getting them to actually be able to say, I saw you didn't fill this out. Why? And some people might say, well, because I believe in a race blind world, right? Which is what some people might say. And somebody that's able to say to them, like, well, here's why it's really helpful to fill that out, could be really useful. And so thinking about training everybody to be sort of part of that discussion, if you will, is really important.
Thank you. Karen?
Sure. So I agree that we should all be helping to gather the information. My cautionary note is something our members say. They say to me, you all ask a lot of questions, and then I go to the next person and they ask me the same questions. Can't you all just talk to each other, right? And so there's something in the human-centeredness of our design that needs to account for that, so we're not creating unnecessary abrasion. The other component, which I don't believe, I know I was late getting on, I didn't hear us talk about, is around trust. If in fact, I believe that we are in relationship, if in fact, I believe that in this relationship, you truly care for me, you don't even have to ask me the question. I'm going to reach out to you and say, can you help me with fill in the blank? And so somehow in our rush to do all the things and get all the information and all those things, we must determine the best way to establish an effective and trusting relationship early on, because it pays so much dividends. I've members who we helped with something so many months ago or even years ago, when things go wrong, they still have my number in their phone, right? And so it's a matter of creating, because they know, they're like, I usually don't tell them right off the bat I'm the CEO, right? You know, because that would create this hierarchy in the relationship. And so we talk, and then they say, well, what do you do? I tell them, they're like, I've never talked to the CEO before. In doing so, we've created a dynamic where we're equals, right? And so I would just encourage us to think about how to better establish relationships and lean in on that. The other piece is to start where the other person is. So very often we start with, for example, some of my team, we have to work on this together all the time. We have pay for performance measures, right? So we're very acutely aware of those things that tend to impact that. And then of course we all have, our HEDIS measures. So we tend to want to lean in on those. And so again, go back to something a lot more human-centered, which is to say, I'm just going to ask a very open-ended question of this person, this other human being, and let's see what comes forward, because it's a much better way to build a relationship.
Great. Thank you. Laquana, you're last up here.
Sure, I'll ditto what everyone has said so far. But the thing that I would add along with that is the fact that when you are looking at who I consider the frontline staff, those who are involved in that process of collecting the information, it's important to ensure that we have certain supportive trainings to help them as well. So if you're looking at trauma-informed care, that approach to, being able to ask those types of questions, noted that when you're asking things related to race and ethnicity, if you have someone that is coming in and they identify as Latinx, there may be some real fear in sharing that information about, exactly, who their race or ethnicity is, because they may feel there's a connotation there that they may block them from being able to receive certain types of services if they provide that information. To be able to have our staff go through things such as, in addition to that trauma-informed care approach, comprehensive risk counseling services, which is a type of training that individuals can go through when they're on that front line to be able to ask these questions. So there's a number of different trainings that we can send our staff through so they can be prepared, so that when those questions come, we are building that trust and we are able to build that connectiveness, so that when they come in and the first time that they ask the question, that's not the first time they've seen this person. So that's not the first time that they've been able to have that relationship with them. So there's a certain level of trust and things that we have to build up with that frontline staff to be able to help with building that relationship, so that then we do get to the back with their provider, whether it is our nurse practitioner or our physicians or whoever it is that they're seeing, our med tech, whoever it is, they are already building a level of comfort with them so they can go in and get to the point where they can share that type of information. And then we can be able to collect and be able to help them with different things. But we've also seen where we've had individuals, and I'll speak specific to North Carolina, where folks are afraid to ask just the question, and they go ahead and they fill out what they think that person is. And so we have a very skewed data on a number of our different Native American individuals that live here in North Carolina, because they never asked the question, just marked to check the boxes, said just white and Caucasian. So it's important to ensure that we're building that training and building that trust with our patients that are coming in to ensure that we're collecting the information correctly.
Great, thank you. So this is the second to the last question. I'm hoping to allow enough time for concluding remarks, so around 10 minutes to the top of the hour, because we're done at the top of the hour. So the next question is, what are the best or most promising approaches for using payment mechanisms to incentivize efforts aimed at addressing social determinants of health and health-related social needs and advancing health equity? What services related to addressing health-related social needs in SDOH and advancing health equity could receive reimbursement under value-based payment models? And the two more parts, can you tell us about existing performance or quality measures that could be used to meaningfully reflect improvements in addressing SDOH and health-related social needs and equity? Is there a need to develop a new measure to evaluate SDOH? I'm going to go ahead and ask Karen, then Marshall, and then Jen, please.
There's a lot in there.
I know there's a lot. So. And we have a short amount of time, so I'm going to ask you guys to laser in on the most important elements here.
All right, I'm gonna jump in on the health-related social needs. Housing instability is high on the list of things that we know are predictors, because it's the basis for our health and well-being. Food insecurity, when you think about chronic diseases such as hypertension, cardiovascular disease, diabetes, healthier pregnancies, right? So those are my top ones in terms of social needs. I also, on the social determinants of health component, I put health literacy high up there, because so many times when we label someone non-compliant, it is because there was somewhere in there a break in their understanding. And so taking the time to ensure that people fully understand what it is they need to know to support their health and resilience is important. And then employment is also high on our list, which we can do so much to become more in relationship in community by offering and supporting employment opportunities, which really help as well in terms of mastery and greater independence. Finally, I would just mention on social cohesion, there is more and more work happening with organizations such as Wider Circle, right, to figure out ways to make that social cohesion happen in a much more inviting, seamless, it's not all healthcare ickiness that sometimes makes people want to step back. So those are the things I believe are important to focus on. In terms of measures, since the health plans have to measure and gather information for HEDIS and whatever their pay for performance measures or focus areas for the state might be, I don't think we should try to immediately come up with something new, right? We can build on what is there. And what we need to do differently, though, is the lens through which we analyze, which I believe has been said already too. We analyze the information. And then finally, in terms of, so how does this come together in a package? Alternative payment methods really can work. They've worked in a number of ways around value-based purchasing. And it's a matter of helping to invest on the front end, especially for smaller practices, or even some mid-sized practices, that maybe we could be more, we the managed care or the state could be more matchmakers, right, to help to create these cohorts of shared services. So if we're talking about a 4-block area where, or a couple of zip codes where having a licensed dietitian really be in that area, then can we figure out a way that they're shared, the scheduling is shared, and then we're leveraging a resource for a greater number of people.
Great. Thank you. Marshall?
So I'm going to build upon Karen's excellent comments, really focusing upon the payment part. I want to focus upon 3 key levers to use. So one is rewarding advancing health equity. This could be rewarding improvement in performance for less advantaged population, having the less advantaged population achieving some threshold key target level of performance, and actually reducing a disparity in performance between more and less advantaged populations. In some ways, that's the low-hanging fruit that a lot of people think of, oh, payment reform, equity, essentially pay for performance. Helpful, but not nearly enough, and so critical. And I would advise the panel to really sort of push organizations to also include the second component, which, building upon Karen's comments about alternative payment models, which is the upfront payment for infrastructure. That again, like Kathleen mentioned this, and Jennifer and all, the importance of flexible money, upfront money, to basically fund the guts and infrastructure of interventions that are required to address SDOH and advanced health equity. So things like personnel, like team-based care, community health workers. We talk a lot about information technology, social needs screening, referral, the community organizations, bi-directional information sharing. And then some of the most exciting works, which again, Kathleen, Laquana, and Jennifer, among others, talked about, were these community partnerships between the healthcare sector and social service agencies. These are things that require this upfront money for action. I love the comment about geography-based. I think it was Jennifer talked about that importance. Critical to align efforts across payers. Hard when it's only one small payer. If you get the federal payers involved, of course, get incredibly powerful. Medicare, Medicaid, other privates. Thinking about how do you align other levers along these multi-stakeholders. So, for example, allowing to include addressing social terms of health in the medical loss ratio calculations in the contracting between payers and health plans is one example. Or the tax status benefit that comes from the community needs benefit. How do you sort of tailor that to then address social determinants in geographic areas? I also mentioned, too, that, again, one of the frontier areas is how do you coordinate with social service sectors, and then innovative ways to blend and braid funding streams. A couple of examples are Rhode Island's equity zones, or some of the work Louisiana did after the hurricanes and some of their buildup that, some ways it would require these type of disruptive, innovative changes regarding the financing schemes. And then third and critical, and we really haven't talked about it so far, is that for those providers, the safety net, that the clinics and hospitals and those providers that serve a lot of particularly patients with a lot of social and medical challenges, they can get killed in some of these plans that use database payment, alternative payment models to address social determinants and advanced equity, unless things are taken into account, understanding their special circumstances. They need more resources. We need to basically level the playing field. So something like risk adjusting payment by medical and social risk. We need to find ways so that we allow the safety net providers to succeed in these different systems that are designed to address social terms of health and advanced health equity.
Thank you. Jen?
Yeah, I was thinking about this at 2 levels. So building on what Marshall just said, at the patient-specific level, we're doing a lot with enhanced payments or adjustments for medical complexity. We can do the same thing for social vulnerability. Again, we have that data at the geographic level. We can create social deprivation indices. The CDC has a vulnerability index that we can use, so we're not putting the burden on our local providers to collect information that may or may not be accurate. Flip the switch now. We're paying based on medical complexity, pay based on social vulnerability. Otherwise, the incentive is for hospitals and any healthcare providers to try to steer those patients away from their hospital to another hospital in order to have their performance look better. The second level is at the community level. Again, communities matter, the place, the health of the community matters to the health of the individual. So are there systems that are making legitimate investments in their communities? And this could be, are they using their data to not locate their primary care in the affluent communities, trying to lure those rich patients into their healthcare system or hospital? Are they using their data, understanding where their sickest and most socially vulnerable patients are coming from and locating their primary care in those places? Again, the incentives are not aligned with doing that right now. The incentive is to go to the rich neighborhoods, let's change the incentives there. Let's identify systems that are doing the right thing. Additionally, large healthcare systems, payers, or anchor institutions, what are they doing to lift up their lowest paid workers? Are those workers able to enhance their education? Are they able to become involved in training programs to do their kids have access to college? Are they able to make a living wage? These are the things that healthcare systems could be rewarded for as well, with some type of Medicaid bonus or Medicare bonus payment or some type of enhancement. Are you doing things in your community that are lifting up the health of your community above and beyond taking care of sick patients and billing Medicare for those patients' care?
All right, thank you. We have, can the panelists stay on a couple minutes past 3, I hope? Okay, because I do want to give everyone an opportunity to provide any additional critical insights that they'd like to share about social determinants of health and equity regarding APMs and PFPMs. Anything around the relationship between them and their potential for optimizing outcomes for patients, and anything around transforming value-based care. This is, maybe a minute and a half or so for each of you. Let's begin with Charlotte.
Thank you. So building on my comments earlier and from the rich conversation from the panelists, there are 3 things. One, I'm on the payment issue. I wanted to follow up with Dr. Chen, talking about payment and MLR, medical loss ratio, and social and personal vulnerabilities that were also mentioned, that we should risk adjust for these. And more importantly, if you are spending effort on dealing with the social and personal vulnerabilities, that counts as a medical expense. And the Medigap population, that counts as administrative expense. It is not an even playing field between Medicare Advantage and Medigap and fee-for-service. The second is I would really caution people to not just measure all the things you are doing, but making sure as you're putting money into the healthcare system in the community that you are not shifting the burden onto the caregiver and onto the patient themselves. What is the time, money, and resource that they are now spending because we are failing to spend on it in the healthcare community? And then the third is, and this is really transforming kind of the value base, not only should we do, going after risk reduction, deficit model, but what are we doing to build the strengths, the personal strengths, a sense of resiliency, purpose, optimism, and changing how we can view how we age, because that ageism costs us 33% more in per member per month healthcare costs, could be as much as $63 billion in healthcare. So I would love to see us remember the person in the midst of all of this as we address the healthcare in the community.
Thank you. Laquana?
All right. I just wanted to share that our 1115 demonstration for healthy opportunities is going to be going on until October 31st of 2024. So I'm hoping that I'll be able to come back to this group to be able to discuss what are some of the things that we'll see in that demonstration, because I do think it'll be able to feed into a lot of the conversation that we're having today. So I'm really looking forward to sharing that as we begin to see that demonstration roll out. We're currently in a capacity building phase where we're building our network leads, we're building relationships with those payers, we're building relationships even with our human service organizations. So as we are doing that, we're documenting everything in every phase so that as we have that information available, we want to be a resource to the rest of you all to be able to share that information and that demonstration that we're doing here.
Thank you. Kathleen?
Sure. I want to share notes from a meeting I did with my community advisory committee after we received our null findings on our RCT. So I met with, and I think most of you know what I'm talking about there. So the 40 people, we explained to them that on readmission, we showed no effect with our care model. And quote unquote, I have it right in my phone here, what they said. This was January 23rd, 2020. And when I'm feeling down, I just go back to it, because it's what we need to do. So they said, we were obviously asking the wrong question, readmissions. We need to ask better questions. How many people got housing and kept up with the program? Think you have to measure how people are involved with their community, their family. What are we helping them with? To go to regularly scheduled doctor's visits, I had to learn those things, and that is how I knew I was getting better. So anyway, I want to end on their voices, but we have to ask them what they need and then measure if we're doing that.
Great, thank you. Jen?
Yeah, I'm just reflecting a couple weeks ago in the height of our COVID surge and our hospital packed to the gill. I spent 7 days attending on our inpatient service, had between 10 and 15 incredibly medically complex patients, most of whom couldn't get into the ICU because our ICU was full of COVID patients. So they were on the floor with our family medicine inpatient team, many of patients from our FQHCs and our family medicine clinics that we serve on the inpatient side. And it struck me, I mean, I know this on the research and policy level, but it struck me on the personal level. Every single one of those patients was below the age of 65, would likely not make it to the age of 65, so would never have access to Medicare. So one, which seems like an insurmountable challenge, but a small improvement for people and a very important way to address their social needs is health insurance. We've done a great job in expanding Medicaid. We have a lot of programs out there for socially vulnerable patients that weren't out there, but certainly if we can't accomplish Medicare for all, maybe we need to think about who gets Medicare and who doesn't. I know this may not be a very popular notion, but if you give people Medicare 25 years before their community's life expectancy, that means that a community with a life expectancy of 95 or 100 might not actually qualify for Medicare until they're 70 or 75 years old. Whereas another community whose life expectancy is 65, very close by, as we've seen those maps that have been put out, might qualify for Medicare at 40. So I know very controversial notion there. Of course, all of us would like to see everyone with health insurance every day of their life, but it really struck me that, you know, these people are so socially vulnerable and so disadvantaged in so many ways that these are primarily people in their 30s and 40s that were on an inpatient unit, whether it be COVID or other medical problems that were likely to end their lives incredibly early, all due to, in every single case of these 10 to 15 patients I cared for a couple weeks ago, social deprivation and social disadvantage. So thinking about that and what we're going to do in our Medicare program, some of them might qualify based on disability, but we know there's inequities in who gets access to Medicare before the age of 65. Most of them will not get any of these great transformative benefits that we're going to make to our Medicare program because they don't live to the age of 65. So something to really consider.
Thank you, Jen. Karen?
Sure. The first thing is around the fact that we need to advocate strenuously for the level of coverage that gives people that equal opportunity, or more than equal, for those places where we see disparities and gaps, opportunity to be healthy. We chase the dollar after we've sometimes had a benefit design that doesn't support health and resilience, right? And so why not invest on the front end? So I would say advocating for the types of benefits and the appropriate payment mechanisms to support them in terms of things like what's been said, including social determinants of health, or how to pay for social risk factors and its mitigation in the payment structure. The second thing is, I don't believe we've talked a lot about behavioral health, you know, carved in, carved out. Whatever we see, oftentimes where someone hits a block, it is either a diagnosed behavioral health condition or one that is not yet diagnosed. And so somehow we can get overly focused on all the medical things and forget that this human being is having a human experience in the ecosystem in which they exist. And if we don't understand what is happening in terms of that experience, are they becoming more depressed? Are they becoming more anxious, right? And maybe not yet diagnosed. And this is beyond social isolation. If you think about what we've learned from the opioid epidemic, if you think about what we've learned where otherwise healthy, no risk factors, no major losses or things like that, what has happened with people during the pandemic, then we should take those lessons forward and invest more in the behavioral health component. And then finally, it's a focus on the provider experience. We often are designing and adding to and not putting enough things on the chopping board in terms of our current model and expectations of providers. And they can only do so much and take so much. So we must rigorously review and be in relationship and conversation to identify what we can stop doing as well.
Thank you. Marshall, thank you.
So we're in year 17 of running one of the Robert Wood Johnson Foundation's major health equity programs. And I'm going to share with you 4 aspects which we feel are the cutting edge of equity now. The first is aligning 4 major stakeholders: the payers, the health plans, the healthcare delivery organizations, and patients and communities. That when you don't get everyone at this table, you rapidly reach sort of a roadblock in how far you can go. And so those interventions proposals that have been truly co-created and co-implemented by these 4 stakeholders working together, they're more likely to have a major impact. A second is that we're going to have increased focus upon patients and communities. We've done that in our program, but we can do better. My guess is that most organizations can also do better in the true involvement of patients and communities. Third, we touched a little bit about this today, but it's actually going to be one of our major pillars of addressing structural racism and social justice moving forward. I mentioned really up front about the importance of addressing both the technical as well as the cultural. And so having these discussions around racism and how that then sort of flows then into the implementation process, buy-in, and actual technical interventions is critical. And then fourth, when it comes down to it, it's critical to integrate at least 3 different elements. One is payment reform. A second is that we just don't leave organizations out in the lurch and figure it out on your own, but there's coaching and technical assistance provided to help organizations think about how they use payment and care transformation to advance health equity. We're big, for example, on the whole learning collaborative idea, where there can be the shared learning and sharing of best practices among peer organizations. But then the third element is, again, this discussion around culture, racism, justice, and ethics. It's just the overlay to everything. And unless that is actively discussed, this is not going to be the buy-in, the prioritization. What's really required at its heart in conjunction with the technical and structural to advance health equity.
Great, thank you. So I'm going to ask if the panelists have just a few more minutes, since we don't have that many folks queued up for public comment. I just wanted to turn it over to my PTAC colleagues if there were any important questions you want to ask the panelists before we wrap. And it's okay if you don't have any, but I thought we'd take this opportunity for any of the committee members to ask the panelists a question at this point. All right. So on behalf of the committee and our audience, I want to thank each of you for your insights today. We are extremely grateful that you've been generous in sharing your expertise and your time with us. This is amazing information, and we will be sure to take your insights and incorporate them into our final document that we'll share with the Secretary. So again, thank you all. It was a privilege to have you on the panel today. Take care. Thank you. So as we transition, we have the next section is for our public commenters. And there's just a handful of folks who have signed up. And the way this works is I will call on the individual and they'll have 3 minutes working through the operator. They'll have 3 minutes starting with their name, title, and organization. And then we'll go on to the next person, and just to ensure that I have everyone who has signed up or wants to speak, I'll work with the operator at the end just to see if there's anyone else. Right now, I've got 2 individuals, starting with Jennifer Gasparini, who's the Director of Regulatory Affairs from the National Association of ACOs. Jennifer?
Great. Can you hear me?
Sure.
Wonderful. So like you mentioned, I'm Director of Regulatory and Quality Affairs with the National Association of ACOs, or NACOs. Glad to be here today to give some public remarks. We really feel that ACOs are uniquely positioned to do this type of work. We're actually just about to release 2 white papers on this topic in the coming weeks, and so stay tuned for more information, but I wanted to highlight a few of the things that we'll be addressing in those papers here today. I think in order for ACOs to do more work in this area, we really need to provide funding to support expanding social services to address health equity, adjust certain benchmarks like financial benchmarks appropriately to not punish ACOs who are treating vulnerable populations, provide grant money to support this work and flexibility in payment rules to allow ACOs to deliver supplemental benefits to patients to help address health equity, and improve ACOs' access to data needed for care coordination to improve equity. And finally, as was discussed today, we do believe you need to reward improvements in this area, which will require more uniform data collection, among other things, so we can accurately evaluate this work that's being done. But again, really just feel that looking across the population, as ACOs do, that they are really uniquely positioned to do this work, and we want to really see models that use ACOs to support this type of ongoing work. So thank you for the opportunity to comment, and we will also be responding to the request for information.
Great. Thank you for doing that, and thank you for your comments today. We had one other person from overseas who was trying to get on, but with the time change, time differences, I'm not sure that person has been able to join us. It doesn't look like that's the case. I'll just ask my staff if there's anyone else who signed up for public comment. And hearing none, that was a brief public comment section. So we now roll into the last section of our meeting. We're a little ahead of schedule. But it gives us an opportunity to refine our perspectives based on what we heard today. This is where the committee members and I were going to discuss our perspectives based on the conversations today, public comment, the one public comment, our guests, and information that Jay and the PCDT presented this morning. As with previous themes, we're going to take what we've learned and write a PTAC report to the Secretary about how efforts to address social determinants of health inequity can be optimized in APMs, value-based care, and more specifically, physician-focused payment models. There's a lot of information to sift through. So I'm going to ask the team, our staff, to share a framework, and they'll put that up that will help structure our conversation. Committee members receive this document. It's in the binders, tucked into a pouch in the binders. And please use the hand raise feature in WebEx. And then Amy will keep me on track to make sure I get comments in the order. So let's just talk about, again, we don't have to cover all of the waterfront, but let's talk about promising approaches for optimizing efforts to address social determinants of health and health-related social needs and value-based care to improve quality and reduce or control costs. And there's 2 subsections here: important activities that should be included. And the second section is extent to which promising approaches are likely to vary based on population, specialty, practice size, geographic area, discipline, et cetera. So that's the first section. I'll open it up to the committee members. Anyone want to weigh in? Important activities that we should include that we heard.
This is Bruce. Something struck me. A number of the panelists mentioned patient-level adjustments for geographically determined social vulnerability. Something I hadn't heard before, and I would only point out at this point that there's a an infrastructure for doing that in Medicare. They have the geographic practice cost indexes, but they're only designed to adjust payments for differences in the cost of doing business. And I wonder if there's, since the infrastructure is already there, I wonder if there's a way of expanding those adjustments to get at the vulnerability factors that aren't typically built into payment adjustments.
That's a great point. So I'm gonna just throw this back to the committee. The professor from Europe did get on the line, and I know we're a little out of sequence, but we have time. I'd love to hear his perspective since he's calling from the other side of the world. If you guys will indulge me, is it okay to have him share his comments?
Yes.
All right. So it's Dr. Jan de Meissonier. He's the professor at Ghent University. Might have pronounced that wrong, in Belgium. Please go ahead, Professor.
Thank you for having this opportunity. I have been working for 40 years as a family doctor. I was also a professor in family medicine and actually leading a WHO collaborating center on family medicine and primary health care at the University of Ghent in Belgium. What we did to address social determinants of health is we started 40 years ago a system of payment, because that's the topic of this meeting, where we have created an integrated needs-based capitation system for interprofessional teams of family doctors, nurses, physiotherapists, and now it will be completed with psychologists and so on. So the idea is that those groups, they work in a community, they have 5,000 to 6,000 people that they take care of. Most are underserved communities where these practices, we have 200 in Belgium, work actively. And they have the patients on their list and they provide integrated care. What's very important is that the team is also a social worker that's paid by the regional government and that helps to look at social determinants directly. And what we have seen is in the assessment of this kind of practice is, and I worked myself in this practice as well for 40 years, is that first of all, we have a very low threshold. The practice I worked in ended up with people from 93 different countries in this practice population. So it was really accessible. At a certain moment, we did a comparative study and we saw that we were unable to create a control group that was as deprived as the group that we took care of in the community health centers with this capitation system. Another important element was that we did not choose for disease-oriented bundled payment programs because those people, most of them have multimorbidity. So we needed really an integrated approach looking at all the different components that contributed to their situation. So housing was important. And what we also did, we implemented community-oriented primary care. So we used the records in the practice to make a community diagnosis apart from the patient diagnosis, where we looked at the upstream causes of ill health. So actions were done in order to, for instance, create green spaces when we saw the bad physical conditions of our youngsters, improve housing conditions when we saw that there were problems in that field. And recently, of course, we organized care and the early diagnosis for the people in this multicultural community when it comes to COVID-19. So what we learned and what the assessment showed that on the one hand, we were very accessible. A lot of people that were below the level of poverty that were cared for. We also took care of undocumented people. Actually, we have more than 250 in our practice. And also when it comes to quality indicators, also in prevention, and that's remarkable for such a kind of population. We saw that we really could reach also with our preventive actions people from very vulnerable socioeconomic groups. And so that was for us a very important thing. Also, of course, we used that for training in order to motivate other providers, nurses, social workers, family doctors, to start working in this kind of communities. Actually, in Ghent, where we have 250,000 people, we have 11 community health centers with more or less 100 physicians taking care of those people. And the target population is not only people living in poverty, it's people that live in a certain geographical area. So we don't want to have a service only for the poor, because we think that if you have a service only for the poor, that risks to become a poor service. And so we try to look at the whole population. And the other thing is we do a lot of advocacy in order to improve the living conditions of our population. And we do that because in Ghent, we have a primary care zone that brings all the primary care providers together. And we have a strong kind of advocacy mechanism to really try to put the needs of our population on the agenda of the local authorities. And actually, it's 40 years that this mechanism of payment exists. What we are now going to do is we are going to refine and improve the variables that are used for defining the needs of the populations we serve, so that we can better adjust for the risks and the needs of our people and organize the payment accordingly. And probably we will be inspired by the ACG, Adjusted Care Groups model, that has been developed by Johns Hopkins, where you use the International Classification of Primary Care codes of your patients in order to characterize their needs, and also then adjust the payment accordingly to that. So that's more or less what we did. And the advantage of this model was that now lasts for 40 years is that it was comprehensive. It took the whole population in an inclusive way and tried to improve the care for that population. Of course, the threshold was very low. There was 0 financial threshold. Of course, in Belgium, we have a collective public insurance for health system. So people have access to the system through the fact that there is a public insurance system. So that was more or less what came up into my mind when I saw the different, very interesting, thanks for that. I appreciate it very much, kind of projects that actually are developing in the PTAC, which I think we have to exchange experiences to learn from each other to better address the needs of those people.
Right.
Thank you.
Well, thank you for your comments. Thank you for reaching out from the other side of the world, from Belgium. And again, thank you for participating today. Appreciate it. I'd like to go back to the framework now. Bruce had just talked about sort of an SDOH gypsy adjustment kind of approach, which I thought was a novel comment, Bruce, and something that, hopefully captures the eye of folks who have an opportunity to actually put something like that in motion. Any other comments from the committee members on that first part about promising approaches for reducing or controlling costs or driving quality?
This is Josh. I actually, I was struck by similar comments as Bruce was, perhaps a bit of a different angle, which is that, I think a few of the individuals mentioned the value of area level measures. We heard that in the morning as well as in the afternoon, or later on, afternoon for me. But then at the same time, we asked a number of questions related to individual capture. And what I grapple with here, and what someone hinted at it, is that on the area level, not every individual will have those needs. On the other hand, the individual is incredibly hard to capture data on for many reasons we all know well. Actually, some studies show that the agreement between those two can be as low as 30 or 40%. And so one of the things I think is really important is gathering more data. To me, I think area level individual play a role. I think as we think about using area level to adjust, though, that's a critical piece of that activity. An important activity is to think about how we braid together in the process of getting to where we want to be, and in that final state, area level and individual level measures. They probably won't always agree, and it's not quite clear to me yet how they should be used, in what kind of sequence to achieve the goals. But I do think that that type of adjustment can help improve quality under this first question.
Thanks, Josh. Any other comments before I roll into the next section, which is really built on the same framework, but this is to address equity and value-based care to reduce or eliminate disparities. Same framework. You know, what should be included, to what extent should approaches vary based on population, specialty, practice size, etc. Any comments there?
Well, Jeff, I think what I heard from a lot of our panelists, especially in the afternoon, is whatever we capture, we really need to keep the focus on the patient, on the consumer, on the individual as it relates to their community. Not just capturing data for the sake of capturing data for the provider community, but really put the needs of the patient first to really have patient-centered care. So that, you know, we don't end up making the same mistakes we've made for 30 years in terms of making it easy for provider, easy to administrate, but really not getting to the root cause problem that we're trying to address. And, you know, it seems in this instance, it really is to be focused on the patient-centered need.
Mm-hmm. Thanks, Jay. Anyone else have a comment on this section?
Yeah, Josh, again, I build on Jay's comment. I don't think they're at odds. I would just complement that by saying I value the second bullet there about kind of how these approaches might vary. What I heard from multiple people was this idea of practices or organizations that could be harmed, right, under payment incentives, mentioning kind of urban versus rural size of the practice. And so I think it's incredibly important to center on the individual and their communities. I think if we believe that some of that is mediated by the type of organizations, then that second bullet becomes very important. And that's one of the things that came out to me implicitly from many of the comments. We have to be mindful of that. Looping that back to my first comment about area level measures, right, of deprivation. Imagine two very different organizations. One's large, regional, draws a big catchment area. People travel across areas to get care for certain conditions versus maybe more rural providers, right? And so I really want to kind of co-highlight that point as we think about issue number 2 here.
Mm-hmm. Thanks, Josh. Kavita?
Actually, something Josh said sparked, it makes me think that if we're going to try to end disparities and have appropriately bold goals, that so much of our information gets kind of locked within our own system. And even some of the programs, the gentleman this morning, Dr. Jacob Reich, I'm going to mispronounce his last name. I thought it was fascinating because when he talked about almost everybody does this kind of work where food pantry, in his case, in the afternoon, you know, thinking about like other community-based organizations, we have always had a model of data kind of where we just take it and pull it in. And if you kind of flip it and think about what most people probably spend a majority of their time with, it's around food and work. And is there a way to actually draw kind of some level of those patient-oriented outcomes by capturing some of that data in these other settings? So it can make things complicated and kind of messy, but it offers, I think, such an opportunity because who better knows? Like, I find that in working with those organizations, they know the community much better than I do and know patients much better than I do. And I'm never going to have the kind of time and interface or that unique interface where it feels less hierarchical, which is also a problem in medicine. But anyway, just it brings up for both PTAC as well as an opportunity if somebody is thinking about submitting a proposal. It just gives it's a really provocative idea and one that we, you know, the accountable health communities, I think, started, but you know, you could build off of in CMMI.
Mm-hmm. Thanks, Kavita. I'm going to go ahead and roll into the challenges because I think there was a lot of comments made from our panelists and earlier subject matter experts around challenges. So we'll start with the challenges related to the beneficiary and the caregiver needs. Anyone want to comment? While you guys are queuing up, the thing that struck me the most was actually ageism. And, you know, sort of pigeonholing of older people, like they can't use technology. I've heard that so much, especially working in California, that the older population is just not tech savvy, and her statistics, greater than 70% of older folks are very savvy in the technology space. And that just sort of highlights the need to change our sort of way of thinking in casting these folks and be more open-minded. The other point, being an ear, nose, and throat physician, she talked about hearing loss. And I certainly, in my practice, really appreciated the isolation that people with hearing loss essentially default to, because it's exhausting to have to be asked to repeat to ask people to repeat themselves. And after a while, they just become closed off. And it's just the fact that you could break through with having technology help these individuals better communicate was inspiring to me, particularly when I saw that 46% of them were less likely, to pursue the kind of care that we just normally take for granted. So the ageism concept is something that I think should get more focus. Maybe one other comment around the caregiver burden. We're very quick to quantify the dollars that are spent on Medicare and Medicaid, but I think it's really the unknown significant burden that's placed on caregivers is the amount of dollars that the caregivers have to spend supporting, nursing care that is not covered by insurance, skilled nursing facilities, assisted living facilities. There's a tremendous burden on the caregiver community. People who might have to leave their jobs to care for a loved one, and that's not calculated. And I'm wondering if there's some way to get some directional sense of dollars that are spent and start, figuring out a way to assist caregivers when in providing care structures or care dollars even for those folks because of the burdens.
Okay, I'm connected. Can you reset?
Yeah. What's that? Was that Josh? Maybe that was all right.
Yeah, Jeff, I mean, one of the challenges that I think covers all of these is how do we build a sustainable revenue stream to finance this from an infrastructure standpoint and keep it going on an ongoing operational basis. So, we have the $3.6 trillion spend, of which, let's just, for argument's sake, 80% is for healthcare services, traditional medical services. Are we going to reallocate resources from that pool to fund this? Or are we going to take from additional revenue streams? Is it going to be self-financing through the savings of the traditional costs, reduction in inpatient hospitalization, decreases in ER visits? I mean, what's the sustainable revenue stream so we can achieve this goal?
Well, I welcome others to jump in. I think there was that picture of the little stick figure where 20% of the acute care makes up the holistic care for an individual. That's where most of the dollars, Jay, are going right now. Right. And we're clearly missing the boat because we're not getting the lift. We all know when we embed behavioral health in our primary care practices, the overall sense of well-being for our patients increases dramatically when they have access to behavioral health on almost a real-time basis when those folks are actually in the same clinic setting. So I think we have to find a way to sort of inculcate social determinants into the medical sort of lexicon, if you will, and it's not something different. Because as long as it's something different, the ability to access those dollars are going to be more challenging. That's my perspective. All right. I think the next topic was challenges related to the provider needs, including information about community-based organizations. There was a lot of discussion about this. Anyone have any comments to make on this section?
This is Josh again. I wanted to loop back to something that I think Kavita mentioned earlier. I think the idea of actually something I said and I think she said. I think the idea of capturing individual level data in a comprehensive, shareable way, I think is good, but it's incredibly hard in the context of how we deliver healthcare in many settings to do that right now. So I think so long as this question is, for example, using area level measures to change how providers are compensated in these models versus having providers use things like Z codes or other things or capturing data to screen things, I think it becomes incredibly hard. That to me is a challenge. The thing that kind of was interesting to me, I think Kavita's comment was, are there ways to work with community organizations to not only actually fashion new measures that we should use, but also a broader way of capturing data so it's not all just on provider organizations or not. I think that's a really problematic thing going forward.
Yeah, I agree. What struck me are, look, the physicians, a lot of this is being placed on the backs of docs to try and ensure that A, they're aware of what's available in their communities, B, they can connect to the patients and determine what they need, and C, they can actually refer these people to make sure that they get referrals, and then D, follow up and make sure they actually avail themselves. And that's just unrealistic with the practice of medicine today to expect all of that to be shouldered by the doc. And it's almost, physicians naturally feel, they want to take it on, and it's not the best, they're not the best individual or the best point in order to drive that. And the more we provide the infrastructure for practices to ensure that all those activities happen without it falling on the backs of the clinicians, I think would be a huge win. And I guess the other question that I've seen in different communities that have been faced with these challenges in different parts of the country, a lot of activities are very siloed, and there's a lot of reproducibility and expenditure of resources, financial and otherwise, that are duplicative. And where I've seen it work is where health systems make contributions and leverage their expertise. Not every health system or not every provider or clinic does the same thing. They coordinate and collectively contribute in their own ways where they add the most value on behalf of the social determinant folks who need those resources more readily. So I think it's misguided to build these models where it's the physician or clinician responsibility. It clearly has to be part of the care team, but I would even go farther. I think more of the responsibility has to fall within the communities themselves.
Yeah, I was struck with that same point, Jeff. And just one step further, I mean, it's fairly obvious, and yet it bears repeating that it's such a huge enmeshed system of care, and that every step in that system, you have to have a patient present, then you have to have screening done reliably, then you have to have the data and the results available at the right place at the right time to the right people, then you have to respond, then you have to track the effectiveness of the response, then you have to find your gaps. All of that has to work. Any single step not working in the whole chain of events that leads to improvements, community health falls apart. And so I think your point about a physician practice, that being the focus in the brain that runs all that, probably is misguided, not well trained for that, not resourced for that. Definitely has to be part of the system. What that best model looks like, I think, is still up in the air.
Yeah, the irony of the situation is that as you push things upstream, which a number of our panelists said needs to be done, and what Jeff just said needed to be done, you're you're pushing the spending beyond what's typically thought of spending for healthcare services, right? So how do we tap into that 3.6 billion to provide upstream services that aren't strictly speaking healthcare services, and yet have an enormous influence on our healthcare system, both the outcomes of patients and the costs of care. I'm a believer that we must be able to tap into There's got to be a few $100 billion here and there to support an initiative like this.
Well, and Bruce, to your point, people aren't going to make those kinds of investments recklessly, and they're not going to make them without some ability to monitor the results. And I think that's another challenge that's listed here around the measures that we would need to track progress. First of all, what are they? And two, who would be collecting them and reporting on them? Anybody have a point of view on that? I think one of the panelists mentioned that we shouldn't come up with a whole new set of measures, that we should probably try to adjust the measures that are out there. And I'm certainly a disciple of limiting and standardizing measure sets, because that's just another point of abrasion to the practices to try and hoist a whole nother set of measures on them. So we need to be thoughtful about the burden that might create. I don't know, you can see the questions there related to referrals, screenings. I'll just open it up to you guys. You guys can see the framework. I don't need to drain each slide, but these comments that we're making now will be incorporated into our draft. I think one interesting observation was flexible, upfront infrastructure investments. And to a large degree, it wasn't that long ago, if you remember, that HIE, everybody was, putting a lot of money into physician practices to help get them on an electronic health record. I'm wondering if there needs to be a similar movement, to your point, Bruce, about earmarking certain dollars to try and get the infrastructure, not necessarily in individual practices, but certainly in individual communities, to give them the resources that the practicing community can plug into to help secure the resources that these folks need. What do people think about that? Well, I'll throw that question out there. And maybe as we wrap up, any other observations that you guys want to make before we wrap that the staff can capture to put into into our report?
This is Josh. I'll just add one thing. The gears were turning, Jeff, as you were talking. So, but I think one thing I think is important, one I really appreciate from all the panelists, is kind of the diversity, the different kind of facets of this thing we're trying to wrap our arms around. And I think when it comes down to how we think about payment models, goes back in one part to that issue of evaluation. I really want to understand that we know what works. And it doesn't mean having incredibly restrictive ways of doing things. I think you can allow flexibility, but I think it could be helpful to think about the other side as well, that if we provide upfront flexible things that's incredibly flexible, we may have some challenges at the other side understanding, so what exactly is it that we did and what do you get for it, upstream or downstream, some accounting for that couple $100 billion that Bruce is talking about. And so I don't know if that means like a quasi type of flexibility, but just keeping evaluation in mind within the context of payment models as one of many solutions to address equity, I think is important.
Yeah. Look, and I would say, Josh, your study, your research that you shared with us this morning, it's very complicated. If it was easy, we'd already be doing it. And I'm glad to see that, people are digging in and trying to strike a path to find solutions. And as you said, it's not one size fits all. It's going to be a multifaceted approach. It's very, patient-centric on what their specific needs and circumstances are. Because not everyone is homeless, not everyone has food insecurity, not everyone has a compendium of all of those elements, but many do. And it behooves us, as we're spending $3.6 trillion on healthcare, not to say what the caregivers are spending. It behooves all of us. This is a problem that has to be solved, and it's not a red or it's not a blue problem. It's a math problem. And if we continue to care for patients tomorrow like we do today, there just isn't enough money in the system to make it happen, to drive the outcomes that the patients deserve. So that's just food for thought. Any other closing comments before we move into the last section here?
Actually, Jeff, I just mention one more thing here. I think it's relatively closing. I think one of the things I took away from this whole day, which has been great, I think is that, SDOH is not a monolithic thing. It's like this thing we just adjust away. It's a lot of complexity there. We all know that. On the other hand, though, it's not a laundry list of things. Here are the 25, 40 things. And that the intersectionality of it, right, to your point about homelessness versus minoritized status versus something else and how they cross over, the road in front of us, there's opportunity, but it gets more complex. So I think a lot of the things we're highlighting now and what the challenges are and picking a set of things that are flexible enough, but that we can evaluate, that we can move forward, I think are important, because I think if we defer them, it only gets more complex. So I think those are some of the things I took away from our session today.
Thank you. Any other comments? All right. So I want to thank everyone for participating today, the guest presenters, our panelists, members of the public, all of you folks on PTAC. We explored a lot of different facets of SDOH and equity, including the types of relationships needed to be able to better connect healthcare providers with their local community-based organizations, to address social needs, the data needed to measure progress, how payment approaches can incorporate equity, as we all seek to drive improvement in health outcomes. We know there's an enormous amount of energy. We heard that from Dr. Flower this morning, and interest in this space. We think the PTAC has an opportunity to make a contribution. We're going to have a request for input that we are posting on the ASPE PTAC website, and we're sending that out through the PTAC listserv. And then in closing, on a personal note, this is my last public meeting as the PTAC's chair. I'm grateful for the opportunity to serve on PTAC and want to thank my PTAC colleagues and all of the ASPE leadership and staff for their support. It's been an exciting journey, and it's bittersweet to say farewell to my time on the committee. For the last year of my tenure on the committee, I've had the honor to serve with Dr. Paul Cassell as the vice chair. As I said earlier, unfortunately, Paul was not able to join the public meeting today, but I'm delighted to announce that he will be taking over as the chair of PTAC, and I know I'm leaving the role in very capable hands. Serving alongside Paul as vice chair will be Lauren Harden, and she unfortunately also was called away for a family emergency today, but I know she will be wonderful in this role. I'd also like to mention that this is the last public meeting for another one of the founding members of PTAC, Kavita Patel, Dr. Patel. She's been here since the start, and it's been a pleasure to work with her. And in closing, this has been really, truly an honor. And I wish my colleagues on the committee all of the best. Please take care, be well, and the meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services.